if you are ready.
Yes, doctor.
Okay, start, please.
Okay. Hello, I am Dr. Saida, one of the doctor of this clinic today. Could I confirm that you, Miss Sarah, 26 years old?
Yes, doctor. Correct.
Okay, Miss Sarah, today we are going to discuss about your health condition, and may I need to, and after that I will examine you, that need to look into your body and maybe touching to some part of your body and even do auscultation. Is it okay for you?
Sure, doctor. Definitely.
Okay. Miss Sarah, are you comfortable today?
Yes, I'm fine, doctor. Just I'm unsettled by the event which happened to me, doctor. Actually, I lost consciousness, and this happened to me twice. I'm really
Oh,
scared, doctor. What
I
could
am
be wrong
so
with me?
sorry. I am so sorry, Miss Sarah. And do you have any idea about it?
And not really, doctor. Actually, I went to my GP. He did some blood test, okay, and then he referred me to your clinic.
Okay. And do you have any concern?
Yes, really. What's wrong with me? And is this going to happen again?
Okay, Miss Sarah, if you let me, I want to ask you some question about this problem and about your health condition. You told me that it happened two times. Could I know the first time when it happened?
Yes, doctor. Actually, it happened twice within the last 2 weeks.
Okay, and how much gap between them?
Come again, please, doctor.
How much gap was between them?
Yeah, around 2 weeks, or let us say 10 days, because the last time happened to me was 3 days back when I went
Okay.
to my GP and he did the investigations to me and then referred me here to your clinic.
Okay, Miss Sarah, could I ask that the both time was similar or was different?
Yeah, exactly the same, doctor.
Okay. And do you remember that before it happened to you, do you
Hmm.
remember what exactly you were doing? Like you were
Yes,
shopping
doctor.
and
Yeah.
yes.
So I was like doing some innovations in my home. I was painting my room, doctor. And then suddenly I felt that I felt dizzy. Okay. And then my vision went dark. And next thing I found myself on the ground, doctor. I was really scary about it.
I am sorry, I am sorry. And it happened that just you change your position from the sitting to standing, or no? It was like during your standing it happened.
No, I was standing, doctor, trying to do some painting. Okay. And then
Nice.
I collapsed. Yeah, I wasn't sitting at all.
Okay, on that time, did you notice that with changing your neck position, it happened? Did you notice like with extending your neck, it happened?
Yeah, possibly, doctor, because I was like looking up in the wall and trying to paint.
Okay, I am so sorry. And do you remember that after your falling, what happened after your
Mhm.
falling? Anyone was around that was witness of your falling?
In one occasion, my girlfriend was there. Okay.
Okay.
He said that I lost consciousness for around 1 minute, I would say. But after the episode, doctor, I felt like back to my normal self. I was a little bit unsettled by the event, doctor, as you can see, but I felt quite okay, doctor.
Okay. That on that 1 minute, any shaking in your body? I am telling about
Mm,
your
yeah.
witness
No,
observation.
no,
Any
I don't think, doctor. No, no
okay.
shakiness of the body.
Any outing your water work, like any wetting your pants?
No, no, I did not wet myself, doctor.
Okay. Any biting your tongue?
No.
Okay. And Miss Sarah, I saw in your referral form that you are suffering from the blood pressure, high blood pressure. Is it correct?
Yes. Yes,
Okay,
doctor.
would you?
Actually, yeah. 1 month ago, doctor, I went to my GP. He checked my blood pressure; it was high, and then he told me to check my blood pressure frequently and to record the readings. So it was found that it is only high in my left arm, doctor.
Okay, I'm so sorry. And you remember that how much?
Yeah, it was
Your
around
blood.
150 over 100. In one time, it was 145 over 95.
Okay. Is it reached to more than 180?
No, doctor.
Anytime you feel headache or vomiting?
Yeah, sometimes I get occasional headache, but it is not that a severe headache. Currently, I do not have any problem. No headaches at all.
Okay. Miss Sarah, did this blood pressure, rising blood pressure, is comes and goes or no, it's constant?
It's constant, doctor, but only in my left arm, as I mentioned. When I check the
Okay.
blood pressure on the right side, it tends to be normal, doctor. Sometimes even to low to some extent.
Okay. And did they check your blood pressure in your leg also?
No, doctor.
Okay. Miss Sarah, did you notice that any changes in your feet, toes, any changes in your nails, in
No,
feet?
no, I don't think,
Okay.
doctor.
Okay. And during some activity like ironing, did you feel that you get easy fatigue like in your hand, in your arm?
Not that I noticed, doctor. Sometimes while painting, doctor, in two episodes, I did not faint or lost my consciousness, but I felt my arm is getting weaker, and also I felt some numbness in
Okay,
sensation, doctor.
okay, okay. I
So I had to stop.
understand.
Yeah,
Yes, I am so sorry. And did you ever feel that there is some noise coming from your neck,
I don't
like
know,
fish,
doctor.
fish, like that? You didn't notice?
Sound? No, I don't think, doctor.
Okay. Miss Sarah, did you aware that you have a high temperature recently?
I am getting some hotness, doctor, especially at night. It is not that very high body temperature, but I feel hot.
Okay. And how is your appetite?
My appetite is fine.
Okay. Any weight loss recently?
Yeah, I lost some weight, doctor. I lost around 4 kg over the past 6 months. Although my
Okay.
appetite is fine, doctor.
Okay. And did you have any breathing difficulty?
No, doctor.
Okay. Any heart racing? Did you feel your heartbeat? Your
No, doctor, not really.
okay. Any tummy pain?
No,
Any changes in your bowel habit like loose motion or hard motion?
no, doctor.
Okay. Any changes in your water work like did you feel that the color change or the it's not like before?
No, doctor, but I feel that my water work is frothy. And I remember also once I went to my GB and he checked my urine and he told me that there is some blood, very minimal blood, which I cannot see with the naked eye. And there is some protein also.
Yes, okay, I'm so sorry. And do you have any joint pain?
No joint pain, doctor, but sometimes I do get body pain throughout my body. I cannot specify a single joint which is involved, doctor, but I just feel body pain sometimes.
I am so sorry. And do you have any swelling in your limb?
No, doctor, at all.
Okay, Miss Sarah, I am going to examine you. Is it okay for you?
Sure, doctor.
Okay, I am checking your
Mhm.
hand. Any changes in your nail?
The hands looks normal.
Okay, how is the pulse? Pulse both side?
Okay, the pulse is absent. Which pulse you would like to check, radial or brachial?
Radial.
Okay, it is absent in the right side, normal in the left side.
Okay, and in the neck, is there any bruise?
Yeah, positive carotid bruit, yes.
Okay, and in the heart, is there any murmur?
No murmurs.
Okay, lung is clear.
Clear.
Okay, in the abdomen, is there any bruise?
Excellent. There is renal bruit. Okay, like 2.5 centimeters above and lateral to the kidney, bilaterally. To the umbilicus, sorry, bilateral.
Okay, okay, any organ enlargement?
No, negative.
Okay, in the skin, any rashes is there or bruise?
No obvious rashes.
Okay, any pitting edema?
Negative.
Okay, and muscle force is normal in
Again, power, muscle
upper
power.
side.
Yes,
Muscle power, yes, in upper
yes, it is normal.
limb.
It is completely normal.
Okay, okay, Miss Sarah, could I know what's your concern?
Yes, doctor, what is wrong with me? Really, I felt scary losing my consciousness, and I'm really worried that this might happen again, doctor. So, what's wrong with me, and how are you going to help me, doctor?
Okay, Miss Sarah, you have some the medical issue that we named Takayasu, and it is the medical term for medical condition that involve your large blood channel, and they get sore, and they make this issue for you, the same symptom that you have. Could I ask that is there any special disease running in your family?
Not that I know, doctor.
Okay, and could I know that which medicine so far you take?
No, I do not take any medications, doctor.
Okay, any other concern do you have?
Not really, doctor. So, will this happen again? And is this disease you mentioned? You mentioned something. Takayasu, doctor. So, is it treatable, doctor?
Yes, Miss Sarah, I will tell you that about this disease. Thanks God that this is actually it's not curable, but it's controllable with some medicine. And I will refer you to our specialized team to check your all aspects of the clinical health, and may they will do some blood tests, some more blood tests, and also some imaging to find out to confirm this disease and find out the complication of this
2 minutes
disease.
remaining.
And after that, they will give you proper treatment, and we will with you. We will not leave you, and we will support you for all complication of this disease. And do you want to know more detail about this disease?
Yes, please, doctor.
Okay, as I told you, this is the soreness of your blood channel, and it makes some symptom for you, the same symptom that you had. Also, if we leave it without treatment, may cause some complication. That all this complication can be preventable with the treatment, like may cause your biggest blood channel get distant and get in risk of the rupture, and you will get a risk for the bleeding. But
So, will I need
don't
surgery, doctor?
Miss Sarah, I will tell you that always this disease just will be under control with the medicine, and it's very very rare happen that you need any surgery, and most of the time it will be under control with the medical treatment. Like we will give you some pills, and you have to be under close on observation with our high skilled team that contain that include of the joint doctor, vessel doctor, and also
Mm-hmm.
dietitian to give you health diet. Could I know that what's your job?
Yes, doctor. I work as a cashier in the local supermarket, and It's really affecting me, doctor, because I find difficulty speaking things from the upper shelf. As you know, as I mentioned, it gives me like numbness and pain in my hand. It's really
Yes,
affecting me a lot, doctor.
I appreciate your feeling, and I will involve our social health worker to help you, and also occupational health worker. They will support you. Do you have any other concern, Miss Sarah?
I know, doctor. Thank you. So time up.
Okay.
Okay, doctor, please, could you take me through your case? Mention the positive data in your history and examination.
Okay, Miss Sarah was a young lady, 26 years old, that came with collapse and with the collapse two times recently, and also
Hmm.
she was suffering with high blood pressure, and told me that had in the outside the observation assessment, she had a high blood pressure and asymmetrical pulse, and also she had some blood in the urine in outside investigation.
Hmm.
And in my examination, she had a different she had absence pulse in the right side, and
Okay.
also had a bruit in the carotid the artery, and also has a bruit in the kidney artery, and
Okay. So
uh,
why do you think she collapsed? Why do you think this lady she developed these two episodes of collapse?
yes, because of the carotid artery is affected in this disease, and sometimes they have a dissection in the carotid, and with this position, with
Hmm.
extending the neck, they are prone to prone to the loss of the blood flow to the brain. That's why.
Okay. So how can or what is the usual presentation of cervicocephalic dissection?
Patient has pain in neck area, and
Okay.
the collapse happened for them.
Okay. Did this patient complain of any
And
pain in the neck, or were you able to identify any swelling in the neck?
patient didn't tell me that has a pain, but
Okay.
had a bruise in that. Yes.
Okay. So if I tell you that uh, um, uh, the lesion which led to these two events of collapse is not in the carotid artery, what else you would want to think about?
So, sometimes this blockage in the carotid artery. You mean it's not at
Hmm.
all related to carotid artery?
Yes, exactly. Anything else you'd like to think about?
Maybe still syndrome.
Excellent, excellent. Subclavian steal syndrome. Okay, so regarding her high blood pressure, what could be the possibilities behind her high blood pressure?
Yes, because of the involvement of the kidney artery, and then this renin-angiotensin system,
Okay, so
renin will
renal artery
increase.
stenosis, right?
Yes,
Okay, what
yes.
else? Any other possibility?
Uh, in other-
Okay, so I heard you mentioning to the patient that the most likely diagnosis is Takayasu arteritis. So how would you confirm your diagnosis?
Confirm is with with the CT angio or MR
Hmm.
angio, or if it's not possible, sometimes patient is too much suspected, but in CT angio and MR angio we didn't get any clue. Then we maybe
Hmm.
do the traditional angiography.
Excellent. Okay, so are you aware of any clinical criteria to diagnose Takayasu arteritis?
Yes, patient is lady under
Okay.
40 years old, and
Yes.
its pulse is absent, and different
Yeah. Yeah.
blood pressure more than 10 mg, and
Exactly.
clumsiness in the arm, and
Hmm.
bruit in the carotid artery.
Excellent. Okay. So, how would you treat this patient in general?
Uh,
What is
yes, I
the
will
treatment
start
approach for
with
a patient with, yeah?
yes, I will start
Mm-hmm.
with corticosteroid, and actually I
Mm-hmm.
will refer to
Any
this.
other option?
Sorry, sorry, doctor.
Yes. Which specialty you would like to refer the patient to?
Rheumatologist,
Okay.
but
So you
chili is
are
still safe.
the rheumatologist.
Yes.
Okay. So you are the rheumatologist. With what options you would want to try?
Okay, first I will try corticosteroid. Okay.
Okay.
Uh,
Excellent.
yes, after that, I will go to the azathioprine and or
Mm-hmm.
anti-TNF.
Excellent. Excellent. Okay. Any surgical options, especially
Surgical
for
option,
this patient?
yes, as we have to avoid surgical option, and we
Mm-hmm.
have to give full medical treatment. Then, if it's not possible, then maybe for the aneurysm, they do they put a stent or
Angioplasty. Angioplasty
intervention.
and stenting. Okay, okay. So time up. Very well done, Dr. Saida. You did very nice, by the way. Um,
Thank you,
I'm
doctor.
satisfied with all the skills. I think you have covered everything. Okay, although you missed the female history, and
Yes.
maybe you have to ask also about smoking and alcohol because this is part of the history. It might not be directly relevant in this case, but again, within skill C, which is communication skills, if you omit important part of the history, they might deduct some mark out of your clinical communication skill, which is skill C. Apart from this, I think I have no comments. Regarding her job, she mentioned that she worked as a local cashier in the local supermarket. So in such situation, you might offer social help, okay? But I don't think occupational health is going to be of benefit because most likely they are not going to have occupational health department in the supermarket. Do you agree?
Yes,
However, you
doctor.
can offer social help. Yeah, yeah. Apart from this, sorry. Apart from this, I think you will get the full mark in this case. All seven skills are
Mhm.
are fulfilled. Okay, so very well done. Okay, so this case is actually um, subclavian steel syndrome. Subclavian steel syndrome, most likely due to Takayatsu. Actually, it is a Japanese name. Takayatsu arteritis. Okay, so the patient from outside, actually, the case appeared like three times before, 2016, and then repeated 2017. The first case appeared in Malaysia Center, because actually it is common in Asian population. So the first case appeared 2016 in Malaysia, and then appeared again like twice 2017, appeared in two centers. And it is very easy actually to come again because you might bring a surrogate, and from outside, they will write to you that the patient had absent radial pulse, for example. Actually, one of the scenarios appeared subsequently after the case of Malaysia Center. Another scenario appeared, and they mentioned from outside that the patient was referred by her GP with absent right radial pulse and left femoral pulse. Why? Because I assume that the patient was surrogate. Okay, if you would like to examine the patient, you will find nothing, no findings at all. From outside, they will mention that there is absent pulse, and the rest of the history they can cook. So it's very easy to bring this case in any center. So from outside, the complaint of our patient was two episodes of syncope or collapse and high blood pressure. Okay, so I will start analyzing the syncope. After my introduction, I will introduce myself using my third name and my role. I will confirm the patient identity, and then I will take permission for both history and examination, just like Dr. Saida did. So, hello there, is it Miss Sarah? My name is Dr. Tahir, one of the medical doctors in the clinic today. Miss Sarah, we are here. I would like to ask you a few questions related to your health, and I may need to examine you as well. Is that okay? Yes, doctor. I will start by an open question. Forget about what is mentioned in the scenario from outside. Could you please tell me what brought you into clinic today? What brought you in to the hospital today. So, doctor, I developed 2 episodes of loss of consciousness within the last 2 weeks. She gave you the duration, she gave you the number of the episodes. I was very happy that Dr. Saida asked, does these 2 episodes look exactly the same? This is very important because if they are different, then you have to analyze both of them separately. So yes, doctor, both of them look exactly the same. Here, it would be very useful if you ask whether the patient did go to his GP or any doctor about this fainting episode. Did you seek any medical advice? Have you been investigated? Any diagnosis? Any treatment given? Because this sometimes might give you a clue regarding the diagnosis. So, doctor, I went to my GP. He did some investigations, some blood tests, and he referred me to your clinic for further workup. From outside, they mentioned to you that the patient had normal renal profile and electrolytes. Why they mentioned this? Because this is actually hypertension in young patients. So you have to think about causes of secondary hypertension. What are the most common cause of secondary hypertension?
The
Any idea?
pheochromocytoma,
Okay. More common
pheochromocytoma,
than few. Something more common than few.
yes, and hyperthyroidism, and
Okay. So let us say renal first,
renal
renal,
problem.
right? Like renal arteries. You know, this is the most common, right? And then endocrine. Endocrine like what? Cushing-Combs-Liddle syndrome and even licorice intake, right? Renal, endocrine, okay, and there are many. However, the fact that the renal profile is completely normal, electrolytes are completely normal, exclude a lot of them. This patient cannot have Cushing syndrome, for example, or Cushing disease. Why? Because in Cushing, you will find metabolic alkalosis, hypokalemia, and hypertension. And from our side, they mentioned that electrolytes, including potassium, are normal. So it cannot be Cushing. Most of the time, it is not Cons, although 20% of patients with Cons syndrome, they might have normal potassium, but by definition, it is unlikely because in Cons syndrome, you will find hypokalemia and hypertension. Hypokalemia and hypertension. Cushing, hypokalemia and hypertension. Liddle, hypokalemia and hypertension. Licorice intake, hypokalemia and hypertension. So by just knowing the fact that the renal profile is completely normal, including patient electrolytes are completely normal, you excluded most of the secondary causes of hypertension. So regarding the syncope, okay, I will start analyzing the main complaint by analyzing the syncope. Okay, so she mentioned that she suffered 2 episodes of syncope within the last 2 weeks. Okay, and they look exactly the same. She went to her GP, he did investigations, but there is no clear diagnosis and no treatment given. It is for you to decide and to search for the diagnosis. So tell me about these episodes of loss of consciousness. What will happen exactly? So whenever you try to analyze syncope, just like Dr. Saida did, you will divide your history to before the episode, during the episode of syncope, and after the episode of syncope. Most important is before the episode of syncope. We will come to know why. During the episode of syncope, I would like to know whether the patient really lost consciousness or not. So did you feel that you really lost consciousness? And for how long? 1 minute, 2 minutes? Okay. And during this episode, if there is any bystander, any feature suggestive of convulsion, like what? Like twitching of the body, jerking of the muscles, uprolling of the eyes, tongue biting. Sorry to ask you this question, Miss Sarah. Sorry to ask you this question, Miss Sarah. Some people might tell me that they wet themselves during the episode. Anything like that, you have to be sensitive when you ask about loss of sphincter control. Okay, so basically, I am trying to know whether this episode is convulsion or not within, during. And did the patient really lose consciousness? And for how long did he lose consciousness? One more thing, I would like to know if this was hypoglycemia. Anyone checked your blood sugar during this episode? So within I want to know if it is convulsion or not. I want to know if it is hypoglycemia or not. And the third point, did you injure yourself or not? Did you injure yourself or not? The urine is finished. After, I would like to know only one thing. Only one thing. Is there any post-ictal state or not? If the patient is having epilepsy, convulsion, generalized tonic clonic convulsion, before the episode, he will get aura. After the episode, he will be in post-ictal state. So after the episode, Miss Sarah, did you feel that you are back to your normal self pretty much quickly, or you were like confused, having mental fogginess, body pain, body aches, headache? These are the typical features of post-ictal state. So after, I want to know if there is post-ictal state or not. If there is no post-ictal state, no, doctor, I was not confused. Okay, I felt no headache, no body pain. I was back to my normal self pretty much quickly. Straight away, I knew where I were and what happened exactly. So any sudden loss of consciousness followed by sudden regain of consciousness, this is most likely cardiac in nature. Sudden loss of consciousness followed by sudden regain of consciousness, this is most likely cardiac, especially if there is no history of convulsion during the episode. And before the episode, the patient felt cardiac nature of symptoms like heart racing, chest pain, palpitations, and then suddenly he lost his consciousness. Or, for example, he felt bounding pulsation in the neck, and then felt dizzy, lost consciousness suddenly, and then suddenly regained consciousness. This is most likely cardiac. So if the patient felt bounding pulsation in the neck before he loses his consciousness, what causes you would want to think about? What is the main differential here in this case? Any idea?
Aortic regurgitation.
Aortic regurgitation, it is very difficult to cause collapse, right? Aortic stenosis might cause syncope. But when the patient tells you that doctor, before the episode, I felt bounding pulsation in the neck, and then I felt dizzy, and then collapsed to the ground, and then suddenly I regained my consciousness. I was not post-ictal. This is most likely Stokes-Adam attack. The Stokes-Adam attack, which is complete heart block. Complete heart block. And the bounding pulsation in the neck is the Canon airwave. Canon airwave. Okay, so back to our patient. The urine, I want to know if there is convulsion or not. Is it hypoglycemia? Did anyone check your blood sugar or not? And did you injure yourself or not? After, was the patient post-ictal? So my diagnosis is epilepsy or sudden regain of consciousness. So my diagnosis is cardiac if the episode was preceded by cardiac symptoms and there is no evidence of convulsion. Okay, and apart from whether this was post-ictal or not, I will ask the patient, did you regain consciousness spontaneously, or did you take any sugary drinks, for example, or sugary food? Because if this patient developed loss of consciousness because of hypoglycemia, he will not regain consciousness unless receive sugar from outside, right? So before, during, and after. We covered during and we covered after. We will come to before. So before, I would like to know two important points. The first point is warning symptoms. What kind of warning symptoms did you get? Do you know that that you are going to or you are about to lose consciousness? What kind of warning symptoms do you get? Lightheadedness. Your vision got dark. Okay, heart racing, chest pain, bounding pulsation in the neck. What kind of warning symptoms did you get? If the patient is having epilepsy, for example, there will be an aura, right? Like seeing zigzag light, smelling bad smells, electric sensation passing down one side of the body. Okay, so did the patient got aura in terms of warning symptoms? If it is aura, then this is epilepsy. Cardiac symptoms, then this is cardiac nature, syncope of cardiac nature. It can be a structural heart disease like Hookham, aortic stenosis, arrhythmogenic right ventricular cardiomyopathy, or non-structural cardiac problems like WBW, Wall Parkinson-White syndrome, long QT syndrome, Brugada syndrome. I mean arrhythmia. It can be structural or non-structural. I mean arrhythmia. Secondly, it can be epilepsy, as we mentioned. Apart from this, let us assume that the patient told you, doctor, I was coughing, sneezing, laughing. So what kind of syncope you are dealing with now? Coughing,
Situation.
sneezing,
Vasovagal.
situational syncope. Someone has got a very similar voice to my voice. I felt that this is an echo. So this is vasovagal syncope or situational syncope. Situational syncope, actually, situational syncope. Okay, vasovagal syncope. The patient will tell you that I saw RTA, or he was having injection, saw some blood, emotional distress. Then he will develop the collapse. He will feel sometimes sweaty. His heart will become pounding. Okay, then he will collapse. This is vasovagal syncope. So let us assume that the patient told you that, doctor, I was shaving my beard and then I fainted. Shaving beards.
Yes, carotid hypersensitivity.
Carotid hypersensitivity syndrome. Carotid hypersensitivity syndrome. Sometimes the patient might not shave his beard, but he was wearing a shirt with very tight neck collar. Again, it will do like a massage to the carotid center, and then it will result in syncope. The diagnosis is carotid hypersensitivity syndrome. Carotid hypersensitivity syndrome. So, doctor, all episodes happen when I was lying down or sitting and then suddenly stand up. What is the diagnosis here?
Postural hypertension.
Postural hypertension. Then the next step is to search for the cause. It might be drugs like vasodilators, diuretics, okay? Or if it is not drugs, Addison disease. Addison disease. Again, there is a D on it. Then diabetic autonomic neuropathy. So 3Ds: Addison, drugs, diabetic autonomic neuropathy. So, doctor, so doctor, I was doing some painting, like in our patient. I was doing some painting with my arm above the level of my head, and then suddenly I felt my vision went dark. I got lightheadedness, and then I found myself on the ground. What is the diagnosis here?
Subclavian steal syndrome.
Exactly.
Body
This is
hypersensitivity.
typical for subclavian steal syndrome. Carotid hypersensitivity, as we mentioned, the patient will tell you, I was shaving my beard, okay, because it will need some kind of massage to the neck, to the carotid area, okay, for the patient to develop the symptoms. But whenever the patient mentions to you that I was doing some exercise above the level of my head, okay, and then I fainted, this is very typical for carotid hypersensitivity syndrome. I will share a picture. Are you able to see the picture in the screen?
Yes.
Okay, so carotid hypersensitivity syndrome usually happen if you have a lesion, narrowing, or stenosis, or even total block in the subclavian artery, as you can see in the picture. Okay, so whenever you do some kind of exercise with your arm, the affected arm, okay, this will increase the demand, right, for the blood supply. And you have got a stenosis. The blood cannot pass freely through the stenotic part. So the subclavian artery will steal blood out of the circulation of the brain through the circle of Willis. And then you will collapse. This is the pathophysiology behind subclavian steal syndrome. If it is in the right side, the lesion usually in the innominate artery. I mean the brachiocephalic trunk here. If it's in the right side, like in our patient, just a minute, the lesion is going to be here in the brachiocephalic trunk, or in the subclavian artery, but before the origin of the vertebral artery, before the origin of the vertebral artery. Actually, if the lesion was related to atherosclerosis, it has got predilection to the left side. Our patient had subclavian steal syndrome for the right side because the pathophysiology is not atherosclerosis. Do you think a young lady in the reproductive age who has no diabetes, no hypertension, she's not smoker, she's not old age, no family history, no physical inactivity, do you think such patient will develop atherosclerosis? Definitely
No.
not, right? Exactly.
Yeah.
So you have to think about another pathology. Okay. So from the description of the syncope, this patient, most likely, the reason behind the syncope is subclavian steal syndrome. Subclavian steal syndrome. Okay. So regarding the blood pressure, I will ask us some questions to analyze the blood pressure. So when was the first time you checked your blood pressure and it was high? Let us assume that she said 1 month ago. Do you remember the readings? It was 150 over 100, doctor, but it was almost always high in the left side, doctor. Almost always high in the left side. My GP told me to record my blood pressure for a week. And then whenever I check my blood pressure, it will be high in the left side and normal to even sometimes low in the right side. Here she gave you the diagnosis. She gave you the diagnosis of Takayasu arteritis. Why? Because the diagnosis of Takayasu arteritis is actually clinical diagnosis. Clinical diagnosis. From outside, it is mentioned that the patient is 26-year-old female. And this is the first point in the criteria. We diagnose Takayasu using clinical criteria in addition to findings of angiography. This is all what you need to diagnose a patient with Takayasu arteritis. Clinical criteria plus angiographic findings. So the American College for Rheumatology criteria to diagnose Takayasu arteritis. The first point, the patient should be 40 or younger. 40 or younger. So our patient is 26 and female, which is very typical for Takayasu arteritis. I think the female to male ratio is 9:1. The second point is decreased pulsation of one or both brachial arteries. By the way, it is not radial artery. You have to check the brachial artery because according to the criteria, you need absent pulse in the brachial artery. Then the third criteria is difference of at least 10 millimeter mercury in systolic blood pressure between two arms. So she mentioned to you, doctor, the blood pressure is always high in the left side, like 150 over 100, she mentioned. In the other side, it is completely normal, doctor, and sometimes it is even low. So this is a difference of more than 10. By definition, she gave you the diagnosis for Takayasu arteritis. So age-wise, it is compatible with Takayasu arteritis. When you come to the examination, you will detect the absent pulse. This is the second point. Blood pressure, she already gave you the criteria from the history that there is a systolic difference of more than 10 millimeter mercury between the right and left forearm. Okay. For the criteria, you need to search for bruit over the subclavian artery, not the carotid artery. Although the commonest bruit in case of Takayasu arteritis is bruit for carotid arteries. Bruit in the carotid arteries. But for the diagnosis, you are not going to need the carotid. You are going to need the subclavian bruit. So how to check for bruit of the subclavian artery? Any idea? You will come to the supraclavicular area. You will put the diaphragm over the supraclavicular area. Okay, if you hear any bruit here, this is bruit of the subclavian artery. Clear? Clear?
Yes,
Yes, indeed.
Apart from this criteria, if you do angiography, any type of angiography, whether this is CT angio or MRA, I mean magnetic resonance angiography, or even Doppler ultrasound, or even PET scan. However, if you find arteriographic evidence of narrowing or occlusion of the aorta, or it is primary branches, or large arteries in upper or lower extremities. Okay, here this is another angiographic criteria for diagnosis of Takayasu arteritis. Okay, so she gave me the history of difference in the blood pressure. She gave the history in difference of the blood pressure, and age-wise, it is compatible with the diagnosis according to the clinical criteria. Okay, I will finish my history. I will finish analyzing the system involved. Let us assume that I will analyze the CNS or the musculoskeletal or whatever. Okay, after finishing the system involved, I will finish the constitutional symptoms. This patient is actually a young lady with suspected vasculitis. So the typical manifestations of vasculitis, it will be like some weight loss, very vague weight loss, okay? Some mild fever, body pain, arthralgia. This is very typical for vasculitis. Whenever there is a vague diagnosis and your patient is a young female, and she tells you that, doctor, at night I feel hot, I lost some weight, there is some arthralgia. Here you have to suspect vasculitis. You are not a good clinician if you do not suspect a vasculitis in any young lady who mentions such symptoms. So when I come to the constitutional symptoms, I will ask about fever, weight loss, appetite, okay, lumps and bumps. I will finish my constitutional symptoms. Okay, then I will come to the systemic review. So what is the main purpose from doing systemic review if your patient is Takayasu Arteritis? Basically, I will be searching for associations and complications, or complications and associations. So what kind of associations you need to search for when your patient is Takayasu Arteritis?
The renal artery stenosis can happen.
Renal artery stenosis. This is part of the clinical picture and will give you hypertension, which is again part of the clinical picture. But sometimes they will even develop complications associated with hypertension, like hypertensive encephalopathy. Sometimes they will develop stroke, vertebrobasilar stroke. So these are two complications. Sometimes they will develop retinal ischemic lesions, retinal ischemia. Anything else?
Chest pain, claudication.
Chest pain, claudication. By the way, it can affect any organ system in the body. It can give you myocardial infarction. It can give you kidney disease. It can give you stroke. It can affect. It is actually large to medium-sized visual vasculitis. Large to medium-sized visual vasculitis. So any organ system can be affected. Okay. So what about the associations? What kind of associations you need to search for in case your patient is Takayasu Arteritis?
Aortic regurgitation.
Aortic
dissection can happen.
regurgitation or stenosis or dissection. Anyway, this is vascular involvement, right? Which is one of the clinical manifestation. It is not association. By association, I mean different medical condition which is associated with Takayasu Arteritis. Like, for example, in GI, if the patient mentioned loose motion, and these loose motions are bloody, sometimes mucoid, and he mentioned tummy pain, and you did the analysis of the tummy pain, he mentioned it is dull aching tummy pain, mainly in the left lower part of the tummy. What could be the association? Inflammatory bowel disease.
Colon cancer.
Inflammatory bowel disease, not colonic cancer. It is not associated. This is inflammatory bowel disease. Inflammatory bowel disease. Inflammatory bowel disease. So why this patient mentioned that when the GB checked her urine, there was some RBCs and proteins, because it is sometimes associated with glomerulonephritis, inflammatory bowel disease. And then within the musculoskeletal system, it is very important to ask about joint pain, swelling and stiffness and skin rash and so on. Why? Because any rheumatological condition can be associated with Takayasu. Rheumatoid arthritis, SLE, polymyositis, ankylosing spondylitis, all of them can be associated with Takayasu arteritis. Rheumatoid arthritis, SLE, ankylosing spondylitis, polymyositis, all of them can be associated with Takayasu. That's why it is very important to do analysis for the musculoskeletal system in detail. Any joint pain or swelling, any problem with the muscles, any rash or ration exposure to sun, any sore in the mouth or your private region, any history of clots. Do full analysis for the musculoskeletal system to search for the associations. When I finish my systemic review, I will come to the past medical history, like usual. Okay, and then I will ask about the drug history, social history. I will ask about smoking and alcohol, and driving and job. Okay, so if the patient had visual complaint or syncope, better to advise him to stop driving and notify the DVLA. They will assess you, and then they will tell you whether to stop driving or not. Pending further assessment, to be safe, I advise you to stop driving for now and notify the DVLA. Smoking, advice. Alcohol, advice. Okay. Regarding her job, she mentioned that, doctor, I have got problem because I work as a cashier in the local supermarket. And whenever I try to pick up something from the upper shelf, I will feel my hand becoming numb and painful and weak. It's really affecting me a lot, doctor. So here you have to offer some help. This help, of course, might be in the form of treatment. You can give a steroid or other agent. Okay. Sometimes it might be surgical treatment, by the way. They can do angioplasty and stenting to open the stenosed artery. And you can also offer social help. Okay. Occupational help is not always possible. Okay, because usually sometimes the job the patient mentioned, you cannot tell him that I will speak to the occupational health department. For example, a patient who is doing personal business, like a lady who do some sandwiches and then sell them out in the street. She has no occupational health department to inform. Okay, so in such a situation, you can offer her treatment. You can offer her social help. Okay, just try to manage the patient concern and offer help. Okay. After that, I will start to before I examine the patient, I will ask him about his concern. Do you have any concern? So, doctor, what is wrong with me? Why this happened to me? Will this happen again? How are you going to help me? By the way, in the long clinical consultation, I mean in pages 23, the patient might have 3 or 4 concerns. So leaving just 2 minutes by the end of your session to ask about the patient concern might not be enough. Okay, try to take history around 7 minutes, 6 to 7 minutes maximum. And then ask about the patient concern. He will have multiple concerns. Ask him anything else, explore his concerns. Okay, before I answer your questions, or I will answer your questions in a minute. Before that, I would like to examine you if that is okay. So I will take it as permission to start the examination. Examination like usual, if you attended with me before, our examination is VLS. The V is to check the vital chart, The local examination is to examine the patient main complaint. So my patient is Takayasu Arteritis. In order to confirm the diagnosis, I need to apply the criteria. Okay, so as soon as I start, I will tell the examiner, I would like to check the blood pressure in both arms. Okay, so there should be at least 10 millimeter mercury difference between the right and left arm. This is the first one, the first point in your examination. Then I will check pulsation, both in the radial and brachial artery. This is very important because according to the criteria, we need absent brachial pulse, not radial pulse. How to check for pulsation in the brachial artery? Any idea? Below the medial side of the biceps muscle. Exactly. Below the medial side of the biceps muscle. If any one of you put his hand below the medial side of the biceps muscle, you will find the pulsation. This is the pulsation of the brachial artery. If you find in the right arm, for example, it is positive. In the left side, no pulsation. you have Takayasu arteritis, most likely. Most likely. Why most likely? Because there is differential for absent pulse in one arm. So what is the differential? What is the differential for absent pulsation in one arm?
Aorta dissection and Takayasu and aorta. Sorry.
And the heterogenic also due to
Any trauma?
repeated arterial blood gas.
Any
Excellent,
trauma
excellent.
or any type of fistula? Is fistula
trauma
done
due to
because
arterial blood gas testing might affect the radial artery, right? But not the brachial artery. Here I'm speaking about the brachial artery according to the criteria. So as Dr. Saida mentioned, okay, the first differential, of course, it can be Takayasu arteritis. Sometimes, by the way, it can be even temporal arteritis. Temporal arteritis sometimes will cause, because both of them are vasculitis of large to medium-sized blood vessels. Okay, so if I find in my examination clubbing and cyanosis, okay, and the left arm is a small hypoplastic limb, and there is a left thoracotomy scar, and then I put my stethoscope below the left clavicle. The left clavicle, I found to and fro murmur. In the pulmonary area, I found murmur of stenosis. In the aortic area, I found murmur of aortic regurg. So here, what could be the diagnosis? Very clear, right?
Ballot-Crushing
Tetralogy of Fallot with ballot-Crushing shunt.
Ballot-Crushing
Exactly. Tetralogy of Fallot with ballot-Crushing shunt. But however, if my patient, there is no scar, there is no cardiac murmur, there is no clubbing and cyanosis, there is no history of surgery, I can easily exclude tetralogy of Fallot with ballot-Crushing shunt. So I will be left with Takayasu arteritis. Okay, what else? Thoracic outlet syndrome. Thoracic outlet syndrome. But however, thoracic outlet syndrome is not going to cause subclavian steal syndrome. Why? Because the compression is beyond the origin of the vertebral artery. In order for me to develop subclavian steal syndrome, the stenosis has to be before the vertebral artery. So the vertebral artery will steal some blood for the subclavian artery from circle of Willis in the brain. Did you get this point?
Yes.
So in case of thoracic outlet syndrome, because the stenosis is after the origin of the vertebral artery, you're not going to get subclavian steal syndrome. However, you can get absent pulsation. So in case your patient, okay, the main presenting finding was not subclavian steal syndrome, or in general speaking about absent pulse in one arm, and I would like to search for thoracic outlet syndrome. Thoracic outlet syndrome. How to search for this diagnosis?
So there is maneuver.
Exactly. There is some test, okay, which is Adson test. I'm sharing my screen now. If you are able to see the screen, are you able to see it?
Yes, doctor.
Are you able to see my screen?
Yeah.
Yes,
okay,
Yes,
so
clear.
I will try to palpate the radial pulse, and then I will abduct the arm, extended slightly behind the patient, okay? And then I will ask the patient to look away and to look to the side, and on each time to take a deep breath in. If the patient is having thoracic outlet syndrome, he will feel numbness, pain, some weakness in the affected arm. Okay, as you can see in the picture. I will palpate the pulse and then abduct the arm, extended slightly backward, and I will ask the patient to do 3 steps. First, he will look to the side, okay, and then take a deep breath, and then extend his neck up, and then take a deep breath, and then look away and take a deep breath. Okay, in each position, if you get any numbness, pain, and weakness, this is typical for thoracic outlet syndrome. Is it clear?
Yes, doctor.
Okay. So differential diagnosis for absent arm pulse in one side is Takayasu Arteritis, or sometimes temporal arteritis, tetralogy of palate with balactosic shunt or thoracic outlet syndrome. So when I start my examination, after checking the vital chart, I will try to apply the criteria. Blood pressure on each hand, pulse, both radial and brachial. On both sides, I will find that the pulse is absent in one side. Okay, then I will search for 3 bruit. I will search for 3 bruit. Okay, because in the criteria also, there is bruit over the subclavian artery. This is one of the criteria. So I will search for bruit of the subclavian artery. I will put the diaphragm of my stethoscope in the side of the absent pulse. If I listen any bruit over the supraclavicular area, this is subclavian artery bruit. And then because the carotid artery is the most commonly affected artery, I will search for carotid bruit. It's the most common bruit, actually, not commonly affected artery. Because Takayasu arteritis will affect the aorta and its main branch. The most common bruit is carotid. So carotid and subclavian. And what is the third bruit? Our patient is having hypertension. So renal artery bruit. Exactly. So how to search for renal bruit? I will search for the umbilicus. And then 2.5 centimeters above and lateral to the umbilicus. 2.5 centimeters above and lateral to the umbilicus. On both sides, I will put my diaphragm and then press. Okay, diaphragm or bell? I think it is the bell or diaphragm. Diaphragm. Someone to help us. Was this the diaphragm or bell to listen for? Diaphragm, exactly. Diaphragm, okay.
Sure.
So 2.5 centimeters above and lateral to the umbilicus. I will put the diaphragm to search for any bruit. So 3 bruit: subclavian, carotid, and for renal artery stenosis. Okay. Then I will just do quick screening to make sure that this is not something else. The cause of different arm pulses is not related to something else. Like, for example, I will search for features of palate tetralogy with balactosic shunt. I will make sure that there is no left thoracotomy, full stop. This will exclude balactosic shunt. Even in the past medical history, if you ask about surgery, you can exclude this. Okay, and then if I suspect thoracic outlet syndrome, I will do Addison test within my general survey. Then my examination is done. I will come to explain to the patient just like Dr. Saida did. Okay, you lost consciousness because you have got a narrow blood vessel. This is happening to you because you have got a medical condition which is called Takayasu Arteritis. Okay, we need to run some blood test and we need to do some imaging. I'm not going to tell her CT or MRI or ultrasound. All these are jargon. Imaging or scanning. Imaging is better. Okay, and then we will involve the joint doctor to start you on treatment. Is it treatable, doctor? So there is no permanent cure, but it is controllable and there is some medications we can try. Will I need surgery, doctor? Sometimes surgery is needed to open up the narrow artery. Okay, is it clear?
Yes, doctor.
Any question regarding this case? So whenever you find,
can I ask you please first?
Sure.
Okay.
Yeah.
Can we consider also aortic coarctation and Bichat's disease for this case as differential?
Aortic coarctation. What is the
coarctation? Yes.
What is the presentation of aortic coarctation?
Hypertension
usually and radiofemoral delay, but it is. I don't think it will cause absent brachial pulse. I don't think it is one of the differentials.
Can sometimes happen before the left
before the
subclavian artery
of the left subclavian artery. Delay or absent pulse? I think it was
The
delay, not absent,
delay,
right?
yes, delay,
Yeah,
yes.
exactly.
Radio
So in
delay.
Takayasu, you will find completely absent pulsation in one side. Okay, and the pulse and the blood pressure also, there will be the difference more than 10 millimeter mercury between the right and left side. Okay,
How much?
so
How
just
much?
final
How much,
points,
doctor?
more than 10, more than 10
Okay, thank you, doctor.
in the systolic.
Which has disease as
Yeah.
differential?
Bahjat disease.
Yes.
Bahjat disease, you will find oral ulcer, genital ulcer, history of thrombophlebitis, clots.
Because I don't remember asking about those orogenital. Also, and the doctor said I did not ask. I remember about vision. I think.
Yeah, within the musculoskeletal system, it is very important to do detailed analysis of the musculoskeletal system, because most of the rheumatological condition can coexist with Takayasu arteritis. Most importantly, rheumatoid arthritis, SLE, ankylosing spondylitis, polymyositis.
Okay, doctor, can patient have suffered from mesenteric ischemia?
Yes.
And in this case, should refer to dietitian or no need if there is mesenteric ischemia?
No, mesenteric ischemia is acute medical condition. Possibly the gastroenterologist.
Sometimes can be chronic. Sometimes can be chronic mesenteric ischemia.
It can be chronic as well, yes. It can be chronic, yes. But I didn't get your point. What is the role of the dietitian here?
Like food not difficult to digest, I think. Like oily food, maybe till improve till treat the patient, improve the patient condition.
I will ask you another question. How to investigation wise, we know how to diagnose now, right? From the clinical criteria and the angiography. So how to assess the disease severity?
How much affects the patient? How much the organ
it.
affected? How much the organ affected?
Exactly, correct. So clinically, in addition to that, I can do ESR, CRP, and there is a specific acute phase reactant. A specific acute phase reactant. The name of it is bentraxine 3. Bentraxine 3. Okay, they found that this acute phase reactant, okay, is highly specific to assess the disease activity even more than ESR and CRP. Usually, if the result is more than 1 nanogram per ml, this indicates disease activity. So ESR, CRP, and PTX3.
Okay, last question, doctor. For this case, should tell the patient to inform DVLA if she's driving?
Yes, because she had episodes of syncope. Okay, and sometimes also they will develop retinal ischemia. It is very common, by the way, within the complication. Mainly the complications are retinal ischemia, okay, stroke, and hypertension. Even hypertension can result in hypertensive encephalopathy and other features of hypertension complication like retinopathy. Exactly.
Okay, doctor. Now I remember the important question. Should ask the patient also. My God, if she has because subclavian steal syndrome, the patient usually have posterior fossa symptoms. I remember, or not always.
Some not always. Usually they will develop with syncope. Sometimes it might be asymptomatic, and sometimes they might develop stroke, ischemia.
Okay, because vertebral artery for cerebellum and pons and blood supply for those parts.
Exactly. Okay, so what about biopsy? Can you take biopsy from the artery to confirm the diagnosis?
Exactly. No, in this case, no.
It is not exactly. It is not practical and not done because it is very difficult to take a biopsy from a large artery. There is risk of bleeding and so on. And usually the histological finding is going to be pan-arteritis involving the entire thickness of the arterial wall. And they will be granuloma and giant cell. However, the diagnosis, as we mentioned, is clinical plus the angiography. Okay? Is it clear?
Yes, doctor.
Okay, any more questions?
Hello, Assalamualaikum, sir.
Okay. Yes, please.
Sir, I have one question, sir.
Yeah, please tell me.
Yes. Sir, regarding that Takayasu arteritis and also subclavian steal syndrome, both are blood pressure and pulse is different in the limb. So,
Exactly.
so what are the other findings that we can differentiate by the patient presentation and in the finding between these two, subclavian steel
You are
and
asking about
Takayasu?
the criteria to diagnose Takayasu?
Yes, yes.
Or
What
what
are the
exactly?
patients or what feature? What's the patient's feature in the
Okay.
like
So
how
subclavian steel, doctor, is sometimes basically subclavian steel syndrome is actually stenosis of the subclavian artery. Why the stenosis happen? Because of Takayasu arteritis, inflammation, fibrosis, and so on and so on. Both of them can happen, either stenosis or aneurysm. So basically, the diagnosis is subclavian steel syndrome. I mean, subclavian stenosis as a result of Takayasu arteritis. Got the idea? Regarding Takayasu arteritis, how to confirm the diagnosis using the clinical criteria we mentioned, in addition to the angiographic finding. Then you have to search for complication and associations, as we mentioned. Okay.
So in the presentation, we will found that there are different paths, and after that, we need to evaluation by investigation, like
so
CBC,
regarding
SSAP.
regarding the criteria to diagnose Takayasu arteritis, you have to found 3 out of 6. 3 out of 6. So the first point is age 40 or less. Okay, decreased pulsation. Okay, or absent pulse in one of the brachial arteries. Difference in the blood pressure of more than 10 millimeter mercury in each side. I mean, if you check the blood pressure in the right side and the left side, you'll find that the difference is more than 10 millimeter mercury. Bruit over the subclavian artery is one of the criteria. And then the angiographic finding. And also, by the way, it's very important to ask within the cardiovascular system about intermittent claudication, because this is another point. This is the point number 6 within the criteria, intermittent claudication. Okay, so any pain while walking, any pain in the leg or in your calf while walking, if she says yes, this is 1 point. You need 3 points to diagnose Takayasu arteritis. Is it clear?
Yes.
3
So
out
if
of
any
6.
patient yes, sir. So if any patient subclavian steel syndrome, will so if asking us that what is the main cause, so we will tell first Takayasu arteritis, and what are the second?
No. It is not like that. Not like that. The first cause is atherosclerosis. Atherosclerosis. Then it can be vasculitis. One of them is Takayasu. Then it can be renal artery fibromuscular dysplasia, for example. But this will cause renal artery stenosis. So the most common is atherosclerosis. Okay? If your patient is young and healthy and no atherosclerotic risk factors, then you can think about Takayasu arteritis. Did you get this now?
Okay. Yes, sir.
Okay.
Yes, sir.
Okay, so this is the end of our session today. Thank you for attending and see you next session, inshallah. Goodbye.
Thank you, Doctor.
Goodbye.
Thank you.
Thank you.